So friend, yesterday we started with sulfonamide. We have seen brief history about it. We have seen how it came into market from prontosil dye, how Domac was responsible for it, and then how so many analogs of it were synthesized, and then how it lost its interest or its importance in the chemotherapy because of the resistance. We have seen various types on the basis of their pharmacokinetic properties, that is short acting, intermediate acting, long acting, and variety of sulfonamides we have classified. Now let us go for general pharmacokinetics of it. This pharmacokinetics, we have seen that it is depending on the protein binding and presence in the tissue for long period of time. On that basis, these can be long acting, short acting, or intermediate acting. So these all are orally absorbed. The plasma protein binding is variable 10 to 95%. As I told you, those which are having more binding, they will have more activity. They can cross placenta. So while using in pregnant female, care has to be taken. Very important feature about this is they are metabolized by acetylation. If those who will study it from books, they will find that there are genetically there are variation of people, or there are different genotypes. We call them as slow acetylators and fast acetylators. So this is because of the microsomal acetyltransferase activity is there. So slow acetylator will cause comparatively slower acetylation. Fast acetylator will cause faster acetylation. Now acetylated metabolites, they are inactive, but they produces crystal urea. Crystal urea means they get crystallized in or they form the crystals of the uric acid and all, and they causes injury to the nephrons. So this is the biggest problem. Now it is easy to understand. Those which are having fast acetylators, they will have more chances of crystal area. So these are how these genetics are impacting, how these genetics are there. We have studied it, or rather you can study it in the just a minute. Let me check. Deepak. Sorry, I don't know why it has happened. I hope now it is visible. So what we have seen is it is orally absorbed. Protein binding is around 10 to 95%. It can cross placenta. It is metabolized by acetylation, and it is very important feature which is linked with its adverse effect, which is major adverse effect, that is crystal urea, which can cause kidney damage. So this is how this is resulting into. It is anybody's guess. Those who are studying, those who are having rational application, they can understand. It will be more in the patient which are having fast acetylation. If it is slow acetylation, it will be slowly there, it will not accumulate, and it will be excreted easily in the urine. So those which are fast acetylated, they will be more prone for the crystal area, and again they will need more dosing because this acetylation will be rapid in these patients. So these are different situations, and how pharmacogenetic different genotypes, they can affect these phenotypes of the people. Then next in that is what are various adverse effects. As I told you, one is very important is crystal urea. It is dose related. and for that what we treatment we can give is give more fluid, give alkalizers. It is very very essential to give uh, these alkalizers. Then fixed drug reactions can be there, and hypersensitivity, again this is very very uh, dangerous one, that is called as Steven Johnson syndrome. It is named syndrome is there. It is severe hypersensitivity, and that causes photosensitization. It causes the skin exfoliation dermatitis. It is very commonly called as, that is exfoliative dermatitis. Means exfoliative means just like peeling off, just like you are peeling off some vegetables, you know, you remove the peel, or some fruits you remove the peel, like that the skin is getting removed. That is called as exfoliative dermatitis. And it can cause dryness of eye, severe dryness of eye can be again very serious, because it causes total dryness, and eyes can be affected, or it can be for long period time it can be there. There is a photosensitization, that means what's your sulfonamide that is coming under skin, that when light comes or on that, that will cause skin injury, very rashes and all. It causes hepatitis, it causes contact dermatitis. Contact means whenever sulfonamides is applied to skin, it will cause inflammation to skin. It will cause hemolysis in the persons which are having G6PD deficiency. This again you will see it in antimalarial treatment also, because these enzymes are very very important for glucuronidation. They causes glucuronic acid conjugation, and because of this, if this deficiency is there, again there are genetic features are there. Some of the races are there, they are having, particularly African people, they are having comparatively lesser activity, or there is a deficiency of glucose 6-phosphate dehydrogenase. In these people there will be hemolysis. Hemolysis means breakdown of RBCs, and that can be dangerous. Then kernicterus, that is jaundice like situation in the premature babies. We have seen that it can cross placental barrier, and therefore in that it will be having this premature people, there will be increase in the bilirubin. And if the bilirubin is increased, if the bilirubin concentration goes high, then that can cause problem, that can be a dangerous situation. There are various sulfur containing drugs like dapsone, sulfonylureas. These are protease inhibitors. Some carbonic anhydrase inhibitors, that is they are diuretics. Celecoxib like valdecoxib, loop diuretics, thiazides. I told you, if you remember, I told you about the development of drug, that on the basis of adverse effect, sulfonylureas and some of the diuretics were developed, like loop diuretics. So these are all sulfonamide in nature, and this why we are giving. There are two things. If they are simultaneously given, they can increase the adverse effect is one thing, and second thing is these are the basically developed from the sulfonamides, because on the basis of adverse effect of the sulfonamides, some of these are there. Dapsone actually is itself is sulfonamide, is antibacterial, so usually we do not combine it, but there are chances that sulfonamide is combined in the diabetic patient, or in anti-HIV patient, or as a diuretic in carbonic anhydrase inhibitor, or loop diuretics, or painkiller is given. Usually these are very common situations. So in that, so almost all diuretics you will find that they are thiazide. You know all the diuretics, loop diuretics, thiazide diuretic, except spironolactone and this kind of diuretics. Almost most of the diuretics, they are having sulfur containing atom, so that can build sulfur into body. So what are the fixed drug reactions? They are named because they recur at same site with each exposure. So the drugs which can causing fixed drug eruptions, these are trimethoprim, sulfonamide, cotrimoxazole. Then other drugs are also there, like fluconazole, ciprofloxacin, doxycycline, clarithromycin, some NSAIDs, phenytoin, cetirizine, pseudoephedrine, etc. So they recur at same site with each exposure, and because of that, these are dangerous. They has to be maintained accordingly. They has to be checked. So these were fixed drugs eruptions. So these usually develop within 30 minutes of to 8 hours of the taking drug. They are sometimes solitary at first, but with repeated attacks, new lesions, solitary means at one or other place, but they may appear and existing one may increase in the size. They involve limbs around mouth, eyes, genitalia, and perianal area, around anal area, around anus. They are there. As healing occurs, crusting and scaling is followed by brown color at the site. So these are, as I told, these are hypersensitivity reaction, very dangerous ones. See, these are some of the pictures of that. I told you it can lead to exfoliative dermatitis also. Uh, then Steven Johnson syndrome, which is very toxic epidermal necrolysis. It is also called as a TEN. Toxic epidermal is skin and necrolysis, that is damage to skin. It is a life-threatening skin condition. It can cause cell death of various epidermal cells, and they separate from the dermis. The syndrome is so since it is separating the dermis is epidermis is separated from dermis, we call it as a exfoliative dermatitis. Just now I told you the syndrome is thought to be hypersensitivity complex that affects skin and mucous membrane. It begins with fever, sore throat and fatigue, and commonly misdiagnosed because already in many times because of infection people are having fever, sore throat, etc., and therefore initially it is not diagnosed. Ulcers and other lesions can also appear in the mucous membranes, almost always in the mouth and lip, but also in the genital area and the anal regions. Conjunctivitis of the eye occurs in all about 30% of the patient, and it's, you can see the danger one. These are characterized by confluent epidermal necrosis with minimal associated inflammation. It is an idiosyncrasy. The word was usually called as a genetic one, where whatsoever genetic, or now we call it as a pharmacogenetics. So it is an idiosyncratic or delayed hypersensitivity reaction, or it is because of the pharma, means some of the genetic people with some of the specific genetic makeup, they will be prone to have this kind. Slow acetylaterals, immunocompromised, and patient with the brain tumor which are undergoing radiotherapy with concomitant antilepileptics are among the most risk. Now see, irony is that just now we have seen that those which are fast acetylated, they can cause more chances of crystalluria, and here we see that Steven Johnson syndrome can be seen in slow acetylator. The reason is what? Because crystalluria is because of the metabolites. Okay, while here it is because of the sulfonamide itself, active sulfonamides. So if there are slow acetylators, the persons are slow acetylator genetically, then they will have more sulfonamide in the body for a long period of time, and they are more prone for this hypersensitivity reaction, because it is not sensitivity towards metabolite, but it is towards sulfonamide itself. So and radiation, we have seen they are photosensitive, so radiotherapy can increase the chances. Those which are immunocompromised, there are chances will be increased, and some of the anti-epileptic, they will also add into the adverse effects. Patient with sulfonamide induced toxic epidermal necrolysis have been shown to have slow acetylator genotype, and that result increased production of sulfonamide hydroxylamine, and that is causing actually the allergic reaction or hypersensitivity reaction. These drugs metabolites may have direct toxic effect, and they may act as a haptens. You must be knowing, we have seen this haptens, what are there during allergy or immunology, we have seen this, what is hapten, and they interact with the host tissues, rendering them antigenic. So antigen will not go into more detail how it is occurring. This is all details are there, how it occurs, how various activities are there, how antigen presenting cells and TNF alpha, they all are involved into it, and what it leads to, that I will not add into detail. Then various drugs like allopurinol, lamotrigine. Allopurinol is what? It is a xanthine oxidase inhibitor. Lamotrigine is one of the anti-epileptic drugs. They can increase the risk of developing this Steven Johnson syndrome or this TEN. Risk is lessened by starting this at the low dose and titrating gradually. So by that time body forms sort of tolerance to this type of adverse effects. And some evidence indicates systemic lupus is a risk factor as well. Systemic lupus erythematosus is again autoimmune skin disorder, and if that is there, then in that people it is more chances. What are the causes? I told you this is because of the sort of autoimmune or disorder of the immune system. Immune reaction can be triggered by drugs or infections. Various genetic factors are associated with the predisposition to Stevens-Johnson syndrome, and the cause of SGS is not known, but as I told you, this drug is getting acting as a hapten. Prerna is always joining late or leaving early. What is the problem? If I'll calculate it, then I am admitting it, but it doesn't mean that join deliberately almost half an hour late. Is there any problem with Prerna? Why so? Almost half hour late, almost joining, or many times if she joins timely, then we'll leave early. Not interested in classes? But this is your record. Many times Prerna this is happening. I'll share these records maybe with parents of most of the students, because I have got record even time at which they enter and at which they leave. I have tried to put a software so that it can come to me, and even I am noticing what people doing. This is not good thing. If those were coming for the sake of attendance from Akash, then Akash can give them like that only. We'll see them during examination, what happens to them. So causes are, they may be after viral infection, malignancies, medications. It can be chances. No reliable tests are there to establish link between particular drug and Stevens-Johnson syndrome. But it is a leading cause is a sulfur drug, because most of the cases of Stevens-Johnson syndrome are because of that. Other drugs like allopurinol, barbiturates, carbamazepine, then valproate, ethosuximide, valdecoxib. These are many other drugs can also cause this one. Now we can see the figures which can show you how dangerous it can be. See, this is how exfoliated. See, the skin is peeled off from the body, the eyes, and it can be very dangerous, almost ulcers and all, and patient. So this is very serious adverse effect with sulphonamides, which has to be taken care of. And these drugs are not there in that, but these are, see, various ulcerations on tongue. These are the whole situation is there, and this is the kernicterus which is there in the bilirubin, which comes to brain and it goes to brain, and it is very dangerous if it reaches to brain. That is what problem with the jaundice people are having. So these are various situations which are very dangerous, and therefore its use has to be very, very carefully done. Then drug interaction, it inhibit metabolism with certain drugs. It can displace from the protein binding site, so it has got that type of interaction also. It causes increase in the concentration of other drug like phenytoin, tolbutamide, warfarin, methotrexate, etc. This is always there. Whenever you will study drug interaction in more detail, this type of drug will always be there, and particularly they are very common, either enzyme induction, enzyme metabolism, and second thing is protein binding displacement. So these are very, very common drug interaction, very popular drug interaction, and therefore they has to be taken care of, or it should be considered. They are rarely used, particularly even nowadays they are rarely used, and if at all used, they are rarely used alone. Usually the only drug now it is available in format is it is sulfamethoxazole and trimethoprim, or that is co-trimethoprim combination. They are sometimes they are used for chronic urinary tract infection. They are topical for conjunctivitis and burn, as I told you, silver sulfadizine which is used in burn. So these are various agents. Then how it is used, as I told you, they are not used alone, then it is used fixed dose combination of trimethoprim and sulfamethoxazole. Preparation is 1:5. It is very common. Ratio at the site of action is 1:20, and it produces sequential block. If you remember, we have seen mechanism of action. It started with first is dihydrofolate reductase inhibition, and second, next one, trimethoprim was causing tetrahydrofolate reductase. Because of this, this becomes synergistic combination. Otherwise, both are individually bacteriostatic in nature, but when they are combined together, they become bactericidal, and therefore they are they were rather once upon a time very popular in treatment. Usually, as I told you, 1:5 was the dose, and that was very clear. Now, one question was always there, that why this is, why this, because there are too many sulfonamides are there. There is sulfasomidine, sulfadimidine, sulfasomidine, so why only methoxazole? Because both are having similar half-lives, trimethoprim and sulfamethoxazole. Now, what will happen if both are having, so whenever there are such kind of fixed dose combination, they should match the half-life. What will happen otherwise? If one is having 3-hour half-life, other is having 7-hour half-life, what will happen? Then one drug will be excreted out of the body. This is a pharmacokinetics, means basic pharmacokinetics, which you should be understanding. So if it is removed from the body in 3 hours, other will remain in the body for 7 hours. What we have seen in general consideration of antimicrobial agents is either drug should always be there. If the drug is not available, then microorganism will find a mechanism to find a resistance to it. Okay, so in that condition, what will happen? If any drug is having lesser half-life, that will be excreted out, its plasma concentration will be gradually decreasing, which will be lesser than the therapeutic concentration or lesser than MIC, what we have seen. If it is less than MIC, then bacteria, it will not able to kill microorganism, but microorganism will use these traces of this as a tool, and they will develop resistance. Now what will happen is, for remaining period, instead of two, which was synergistic mechanism, will remain only one. That is, whatsoever is excreted is gone, and the remaining is there. So for again, whenever it is possible for bacteria, it becomes easy for to find the resistance for when it is a single treatment, and which was earlier bactericidal combination, it has become now bacteriostatic when only one drug is there. I hope you are understanding. So it is very important to have similar half-lives of the drugs. Okay. So if the half-life is similar, then only we can combine, or it should be matching. Otherwise, it will be a problem. Why ratio 1:5? Because trimethoprim has got larger volume of distribution. So because of that, what is happened? Larger volume of distribution is there. That means its plasma concentration will fall down very fast, because it is distributed in more volume. It is going to everywhere, and optimum synergism is obtaining at the ratio of 1:20. So when this ratio, to maintain this 1:20 ratio, we have to give the tablets in the form of 1:5. So this is the reason why it is not harming human cell, because we know trimethoprim is 5 times more selective for bacterial dihydrofolate reductase. Okay, and mammalian cell, they are using preformed folic acid. Is there any agent which is having similar action? Yes, we have many agents which are having similar action like trimethoprim. I told you it was my favorite question almost 20 years back. That is, when what are the drugs which are having similar mechanism of action and different indications, and that is different uses. So yes, trimethoprim is antibacterial, pyrimethamine is antimalarial. It is also having same, it is also acting, but it is acting on the dihydrofolate reductase of which agent, which microorganism, which type of species, that is, these are protozoas. Then there is a methotrexate. We have seen it is during immunosuppressant agents. So this methotrexate is having more selectivity towards human dihydrofolate reductase, and it is also having same mechanism of action, but it has got different selectivity. So when selectivity will change, it will decide safety or action of the drug. Okay. So mammalian cells, they use preformed folic acid, but still it has to be reduced as a folic acid reductase, and thus it has to be done. What is the spectrum? That is, it can act against gram positive, it can act against gram negative. Resistance, they acquire dihydrofolate reductase of lower affinity towards sulfonamides, and therefore they will not use sulfonamides, they will continue their synthesis without even looking towards sulfonamides. Adverse effects of trimethoprim are similar to that of sulfonamides. They also causes renal toxicity. It can cause teratogenicity. It is an antifolate enhanced teratogenic effect of other drugs also. It causes bone marrow suppression. There are many drug interactions which are similar to that of sulfonamide. Cotrimoxazole plus diuretics, it causes chances of thrombocytopenia, because most of these sulfur containing drugs, they are having activity. There are many other drugs which are having antifolate actions, and if they are given simultaneously, then it can cause serious reduction in the folic acid. Example are pralatrexate, like methotrexate, then pemetrexate, proguanil. Proguanil is again in protozoal treatment, pyrimethamine, methotrexate, trimethoprim. These are various agents which are used, which are having antifolate actions, and as I told you, many of them are having different uses. So what are the uses of sulfonamide and cotrimoxazole? They are used in facio-maxillary infections, then respiratory tract. They were, rather we can say, because there are many other safer and better antimicrobial agents are available, but they were very popularly used in most of the conditions like facio-maxillary infection, then respiratory tract infection, urinary tract infection, prostatitis, that is inflammation of prostate gland, typhoid, bacterial diarrhea and dysenteries, pneumocystis, infection in AIDS, cancroids, burn dressing. These were various conditions where these drugs were used. This cotrimoxazole was rather it may be used, but it was a drug of choice in pneumocystis pneumonia, nocardia, Yersinia enterocolytica. Yersinia species are known. Yersinia, one of the very popular was Yersinia pestis, which was responsible for plague. Then Salmonella typhi, Shigella. Salmonella typhi responsible for typhoid, Shigella, E. coli. And these are for various kind of dysenteries, cholera, brucella, atypical mycobacterium. In all these cases, they were used. So here we finish sulfonamides. I hope it's clear to you. And if you have any difficulties, you can put the things in the group. Okay. Take care and be safe. Stay safe.